So, I'd like to welcome everyone today. We are talking about bone and joint health.
My name's Jason Lowry. I work here at Arlington Orthopedic Associates. We cover the Mansfield and Arlington area. I have a special fellowship training in adult reconstruction, which means I work primarily on hip and knee replacements. Take care of a lot of patients with arthritis, so weekend warriors that are wearing their joints out. Some of us that wish we were more warriors than we are, with worn out joints. Also take care of a lot of patients that have bone problems as well. And
Okay.
so kind of the gamut of general orthopedics with a specialty in hip and knee replacements.
Okay.
Mhm.
Which is like the most popular thing, I would think, if there is such a thing as a popular thing.
Well, yes, in terms of the most prevalent out there, definitely of all the joints that are replaced in the body, probably knees are number one by far,
Mhm.
with a close second is hips, and probably followed by shoulders.
Okay.
And so the three largest joints in our body tend to get worn out the quickest, and obviously our knees and hips tend to take the brunt of our daily life, and so those are the most commonly worn out.
Okay.
Yeah.
So, when we talk about knees and hips, what are some of the most common symptoms that you've begun to have some wear and tear on that?
Sure. I mean, pain's usually the first symptom, but something subtle is just some stiffness, maybe some mild aching. Those things occurring when your normal daily activities, things were pain-free. Those might be some early signs of the joints having problems.
Mm-hmm.
A lot of folks will say usually stiffness, like if they've been sitting too long.
Yes, I do know.
Yes. And then obviously the just activity related discomfort or stiffness. And so the more folks walk, the more they get little achy joints, and things are little creaks and pops here once in a while. All those the sounds and creaks and pops can be typically normal in some joints. If they're associated with some stiffness and aching, they can be usually a sign of early arthritis.
When you begin to experience that, because we all do at certain ages, right? How much of it is stuff that is just considered normal? And then at what point does it go beyond that where something needs to be done?
Yeah, I mean, obviously, yeah, the common sense would say if you're doing some activities that you're not used to doing, that your body's not used to doing, and you have a sudden change and increase in activity, having some basic soreness is going to be normal aching. But if it gets to where that doesn't go away after some appropriate rest and maybe some over-the-counter Advil or ibuprofen, and it still gets to being worse, then I usually advise folks to come in and we'll get some x-rays and get it checked out.
Okay. Now, when it comes to the replacement itself, because is that really kind of the major thing that can be done? I mean, when it gets to the point where is that kind of like your end of the road?
It
You
is. It's kind of, yeah, that's the final, really what we call the definitive treatment. And so, but it just depends where folks are when they present on where the arthritis disease or the joint wear is in the stage. So, but we definitely try and conservative treatment first. And obviously we're realistic with patients. If they come in and their joints are just worn out and it's a disaster and their life is just, ruined and it's a heavy negative impact on their life, then we try some conservative treatment with the idea and the caveat to say, hey, here's the reality of the situation. Your joints are worn out and it doesn't really matter what we're going to do. Eventually joint replacement is going to be the definitive thing.
So what's new on joint replacement?
So, the technology of the actual implants themselves, there was probably a decade or a decade and a half ago, there was I think a big improvement in how the materials were made and to improve the longevity of the materials. What has improved since then is more of how we do for instance, knee and hip replacements. So probably the past 5 to 6 years, there has been an increased utilization of robotic assisted surgery. Okay. And that has allowed us to, really fine tune how we do the hip and knee replacements. And that I've seen that in my practice. It's been very compelling to see how we can fine tune doing the surgery with the idea of making them last longer. That's been the goal.
Okay. So it's the surgery itself, not the piece, replacement piece that has.
Yeah, I think from a technology, at least if you look at the past 5 to 6 years, really where the focus on technology in the space of hip and knee replacements, it's been on the actual process and implementation of the procedure versus the actual materials.
Okay.
So, from a timeline standpoint, if you look at the surgeons and my mentors that trained me, or my cohorts,
right.
Those surgeons would have been in practice in the 80s, 70s, 80s, early 90s. The problems with joint replacement back then had to do with the materials.
Yeah.
And especially the wear of the what's called the polyethylene. Polyethylene is a material that kind of replicates, it's our best way of replicating God's cartilage that he made for our joints.
Right.
And it's a plastic, but it's a durable polyethylene material. And so the way that's made and processed was really improved in the mid to late 90s and early 2000s. And that helped solve some of the problems they had in the 70s and 80s.
Okay.
And so once they solved that problem, really the big focus, I mean, there's still obviously some material changes to tweak here and there, but in terms of where a lot of the research has gone, focusing on improving outcomes of hip and knees, it's been really on the robotics side, or at least maybe not straight robotics, but some other kind of technology to assist the surgeon on how we do the surgery.
Okay.
Yeah.
So I've always heard that a replacement has a lifespan of about 10 years. Is that still the case?
No, absolutely not.
Okay.
And some of that comes to do
good.
with that technology, with the implant material. So yes, so like I said, the same surgeons that trained my cohorts of surgeons, that was the adage, was 10 years. That was the quote.
Okay.
But now that polyethylene durability has gotten so much better, I quote patients 30 years plus.
Yeah.
And then the whole idea with adding the robotics into the equation allows us to hopefully improve the longevity even further.
So the robotics, because, and again, I've always heard that a knee replacement surgery was really almost horrific in how the process of it being done. If you were watching it,
depends on who you are.
Okay.
Horrific or eloquent.
Okay. But so you're saying then with this new robotics, it's not as drastic?
I wouldn't say. Yeah, a lot of folks will use the word invasive. So is it more? Is it minimally invasive? Meaning, is it less damage to tissues, things like that? So there are some studies that show that there is less tissue damage during a robotic-assisted knee replacement versus a non, and then that will demonstrate itself in pain after surgery, so less pain. So we can objectively, so during the recovery phase while in the hospital, then at home, we can actually, there's studies that objectively measured how much pain medicines people were taking, how much pain they had in the hospital after the surgery, and they compared those to people that had it done robotically versus without, and there actually was a difference. There was a significant difference.
Yeah.
What does that mean in the long-term outcome? Probably not as much, but obviously in this day and age when we're very cognizant of overutilization of opioids and narcotics, it's important. And so I wouldn't necessarily say robotics has allowed us to use a significantly more narcotic pain medicine, but it's helped.
Okay.
So there's a lot of other things that has helped with that too, such as like techniques with anesthesia and nerve blocks and things.
Yeah. So now, do you guys also work on the spine as well?
So
any type of. So
there are in terms of like the robotic technology.
Yeah.
There is. So the similar technology that we're using in lower extremity joint replacements, they are using in robotics, and in fact, some of the technology actually started with brain surgery, with neurosurgeons mapping tumors, for instance, in the brain. Some of that technology started on that side that then translated over to the hip and knee replacement side.
So what do you see in the future when it comes to bone and hip? replacements?
I mean, it just seems like every 4 or 5 years there's fine tuning in a positive way of how we do things, and expecting better outcomes and us doing better for our patients. I mean, across the board, patients do very well with hip and knee replacements, but I always think whatever we can do to make that even better, is an honorable goal, and that's hopefully the field of orthopedics is doing that. It's hard to say. I mean, I think I would see more incorporation of robotic technology in with orthopedic surgery in general. Some other things that are more on the bone health side of things, I'm sure there's going to be people way smarter than me figure out techniques of regrowing cartilage, regrowing bone in a more predictable way. So there's a lot of smart people out there working on those things.
So when it is a cartilage problem, say in your knee, is there an alternative for the replacement of just the cartilage without the whole knee?
There are, and they've been around for a while, and that field has been fine-tuning over the years. So there are some cartilage replacement procedures that a lot of my colleagues do right now. They've been around for a long time, with the whole idea of if the whole knee, let's say for knee replacement, for instance, or knee arthritis, if the whole knee is not worn out, if you just have small little patches of cartilage where they're gone or missing, there have been procedures to kind of patch that area, so to speak, with cartilage. Different techniques have been described for years. To go back, it used to be a transfer where they would take pieces of bone that had cartilage attached to them around the periphery of the knee, let's say, that weren't necessarily the part that were crucial for the knee to move or to put pressure on, that they would transfer and put in that like little divot or crater where the cartilage is missing. So that's a procedure that's been around for a long time. And then there's other things where they would use cartilage cells and a patch over the top of it to kind of fill that in, and hopefully that cartilage would grow in. And so there's been a lot of improvement on that over the past decade. So the problem I have with that is just finding that right person, and so those patients are few and far between. The more it's rare that someone will show up where they have just one little area where the cartilage is missing. By the time they usually see me, things are worn out pretty good.
It's way beyond down the road. Okay. So if there was advice that you would give to us out there, what would that advice be?
Well, you want to stay active, okay? Life is motion, motion is the key for your joints and your well-being. And so you want to stay active to enjoy life. It's just doing those activities or the appropriate activities, and that's going to be different for everybody.
Right.
But in general, being middle-aged and decide, and this is an extreme example, if you're in your middle ages and you decide, hey, I want to get healthier, probably starting to do 10Ks and marathons probably is not the best idea for your joints. I know,
probably not.
It goes without saying, but sometimes you have to say it. So, but maintaining an ideal body weight is very important too, because you just think about it. It's pounds per square inch of force across the joint, and that's when we just walk, And so if you add that onto walking on a hard surface like asphalt and concrete, that goes up exponentially. If you add jogging on that, it goes up exponentially. And so there's only so many pounds per square inch over repetitive lifetime that your cartilage can stand. And
really? That's an interesting statement right there you just said.
Low impact exercises are good, but also your body weight's got, and your primary doctor will like hearing me say that.
Yeah.
If you can maintain a healthy body weight, it's going to help with other things, and definitely joint pain. So I've always had patients that come in, bad knees, they got some significant arthritis, and we were treating it conservatively for a long time. They finally make the life change and they lose 30, 40 pounds. And I've had patients that have held off needing their joints replaced. I've got a couple of patients that say that they're happy and content, and they have some pain, but it's not bad. And so I've had the opposite, where I've had patients where they were quite a bit heavier than they need to be. Their joints were worn out, but not as severe as you would think, and they're not able to tolerate the pain as much, because things are just, the pressure is just miserable for them. So, but no, it's not as common to see patients lose a little bit of weight and then hold off joint replacement for a long time, but I see it enough. you know.
Yeah.
So
Interesting.
Yeah.
It's interesting the comment that you made that it's almost like a how many miles you can get on a tire. How many miles? How many? Yeah. What can
and
you?
it's different for everybody because there's so many factors that play into that.
Yeah.
Not just your body weight. It's some patients, females, are a little more prone to this. With the osteopenia, osteoporosis with bone health. Some patients, if their bones happen to be a little weaker, especially around their knee, it's just a bad combination of things falling into place to where they can have some issues with early arthritis that would be more devastating on them than it would be if their bone health was good.
Right.
So there's a lot of things that factor into it too.
Okay.
So, yeah.
All right.
Yeah.
All good stuff. Anything else we need to know?
No, I mean, it's always choosing the right, what's the right exercise. Again, it's different for everybody, but for across the board for most people, low impact. And so bicycle of any kind, stationary, recumbent bike's very easy, a good place to start, other than just a regular bicycle. But that helps keep the hips and the knees moving, okay? And it's not putting pressure on your joints. I have a lot of patients that like rowing. The rowing machine is a good exercise. If you are going to walk, walking's great. Obviously, it's a lot better on your joints to be walking on a natural, softer surface or a synthetic surface, like a synthetic track, something like that, other than concrete and asphalt. That's why it's great, around town. We have the nature trails. Those are fantastic. And, the hiking trails locally are good. Aquatic exercises are fantastic. And so I joke around with my patients. I'm like, get your rear in the pool. It doesn't mean you have to swim and do the, American crawl and the butterfly. Just get in waist deep water. I got a lot of patients that are worried they don't swim or something,
Yeah.
And I'm like, you don't have to know how to swim. Get in waist deep water, and you can do exercises like you would, on land in the pool. So aquatics are really good too. So,
what's the worst thing that you could do?
Well, I mean, again, if you're the out of shape, overweight, middle-aged person, which is probably more than half of us, to suddenly decide to become a marathon runner or get involved in sports that requires a lot of cutting maneuvers, meaning side to side quick movements. So if you've never played racquetball before and you're 20-30 pounds overweight and out of shape, racquetball might not be the first choice to start your exercise routine. I'll just put it that way. Start off a little easier on your joints, so they'll be happier. So,
Okay.
Yeah.
All right. Well, thank you very much. Appreciate
Sure.
your time.
Yeah.